Good evening, everybody. My name is Jeff Chu. I am one of the newest members of Florida Hospital East, but I am not new to Florida Hospital. I did my 5-year specialized surgery training over at Florida Hospital South downtown, and my relationship extends way beyond that to 32 years ago because I was born at Florida Hospital South. So I feel very fortunate to be able to come back and serve the community where I grew up. My office is just right next door. It's in the second floor of our surgery center, so we're all very centrally located. Today we're going to talk a little bit about the surgical management of breast cancer. We'll start off with a review of anatomy, and some of this is review of review because we've already talked about it before. So when we talk about breast, we divide it into 4 quadrants: the upper outer, upper inner, lower outer, and lower inner. And we classify where our breast cancer is based on these locations. The breast is composed of about 15 to 20 lobes, and each lobe consists of several lobules. In addition, there are fibrous bands that give the breast its architecture and make it look like it does. With Dr. George and Dr. Constance Beers have kind of alluded to before, there are basically 2 structures in the breast. There's lobes, and the lobes empty into ducts, and the ducts empty into the nipple. And the 2 main types of breast cancer that we have are lobular breast cancer, which arise in the lobes of the breast cancer, and ductal breast cancer, which arises in the ducts of the breast cancer. There's also drainage of the breast, and this is important for me as a surgeon because the drainage of the breast goes to what we call lymph nodes. And these lymph nodes are areas where the cancer will spread if the cancer has spread. So these are very important for us in terms of how we classify the degree of spread of breast cancer. The surgical treatment of breast cancer has actually changed in several years, and it's changed very drastically in the last few years. In the very beginning, if we look at surgical text, I was tempted to show a picture of how we used to treat breast cancer, but I thought better of it because all of you would have run out the door because it is very, very morbid. When we talk about the early treatments of breast cancer, we talk about Dr. Halstead and that kind of thing. And when they saw breast cancer, they didn't see breast cancer as we know it. Breast cancer back then would be a patient would come in with a very, very large mass. This has been going on for a very long time. And the only thing we could do is what we call palliative surgery, or remove as much tissue as we can, and the results were not very good. Well, there have been a lot of advances in the treatment of breast cancer from surgery and also from other modalities that have improved both outcome and the way we treat breast cancer in terms of the type of surgery or the amount of surgery that you need. And these improvements are improved systemic chemotherapy. We have very good chemotherapy drugs, and they're getting even better, and that is allowing patients to live longer without cancer and also increasing their overall survival. There's also the addition of radiation treatment. That's very important because this allows us to perform less surgery and also treat the breast without having to take so much of the breast tissue out, and we'll touch on that in a little bit. This is probably the most important thing: early diagnosis. Those of us that do this for a living know that it's patients who come in with early stage breast cancer have a lot better outcome, and they reap the most benefit from the types of advances we've had in breast cancer. Early diagnosis is so important, and it's so important that I'm going to come back to this again at the end of the talk. So, when we talk about early diagnosis, we talk about mammograms. A recommendation that we give, and people who do this for a living, is starting yearly mammograms at age 40. If you have a first-degree relative with diagnosed breast cancer, then you can start getting mammograms earlier than that. Well, this is a mammogram of a typical patient that I see these days. This patient actually had no symptoms at all. Didn't have any masses, didn't feel anything, and didn't have any pain, didn't have any nipple discharge, but she was very vigilant with her mammograms. This isn't the first mammogram she had, but this is her annual mammogram. And what they found was a mass on her mammogram in her breast. Well, when they find a mass, we have to get a diagnosis. So usually what happens is we get we get some of the tissue and we sample it. What happens is the radiologist uses an ultrasound, and they insert a needle into where the mass is, and they take a sliver of tissue. After they take that sliver of tissue, they send it to the pathologist, and they do specialized tests, and they tell you what the mass is. First, is it malignant, meaning cancer, or is it not cancer, and then so forth. After they do the biopsy, the needle biopsy, they always leave a small clip, and it's very hard to see on this picture, but they always leave a small clip to tell you exactly where they biopsied, so that if it does come back cancer, we know exactly where the cancer is. So at this stage, this patient did have a diagnosis of invasive cancer, and that's when she got plugged into the Florida Hospital Cancer Program, and that's where she saw me. The surgical treatment of breast cancer is basically two modalities. Mastectomy, meaning removing all of the breast cancer, or mastectomy meaning removing the breast cancer, but also removing the entire breast. Or breast conservation therapy, which is just removing a part of the breast that includes the cancer, not removing the whole breast. Let's talk a little bit about breast conservation therapy. So breast conservation therapy, yes, is removing a lump of tissue of your breast that has the cancer, but it's actually more than that. When we think about breast conservation therapy, it's actually a bundled treatment, not just surgery. Surgery, which is lumpectomy, removing a small portion of the breast, not all the breast, but we also sample the lymph nodes because we want to know if the cancer has spread. And there are different ways where we sample the lymph nodes. Initially, what we do is we do what's called sentinel lymph node biopsy, or remove not all the lymph nodes, but a select number of lymph nodes to test to see if there is cancer in those nodes. And then if it happens to be cancer in those nodes, then what we do is remove all of the lymph nodes in the axilla or the armpit, and we see how much the cancer has spread. And radiation therapy. So this is actually a three-pronged approach. Surgery, which is our lumpectomy, lymph node staging, and also radiation therapy. The reason why we use radiation therapy is this. When we remove a lump of tissue with a breast cancer, well, we hope to remove all of the breast cancer. We can remove the portion that we see on the mammogram, and we can remove the portion that we can feel if it's a palpable mass. But cancer isn't always something you can feel or see. In fact, they're little cells, and they're so small that you can't see. So when we remove a lump of tissue, we are removing the majority of the cancer, but what really happens is that there are almost undoubtedly some cancer cells left in the breast in the area where we removed the cancer. So we apply radiation therapy to this area to so-called sterilize the breast, or to kill the remaining cancer cells. In large studies, we found that patients who just have lumpectomy and don't have radiation therapy, they don't do very well. The cancer comes back, and their overall survival is actually not that much improved. But when we add radiation therapy to the lumpectomy, we find that they have a dramatic improvement in both disease-free survival, or how long they live without the cancer coming back, and also overall survival. This is a picture from a textbook. It's not my patient. Don't worry about it. It's from the textbook. And this patient had breast conservation surgery. This patient had just a lump of tissue removed from the breast. Now, I'm not going to tell you which breast they had it removed from because I don't know. They didn't put it in the caption, but I think that's the point. This patient had a very good outcome because we removed a portion of the breast with the cancer to the point where we removed all of the cancer. And quite honestly, I'm a surgeon. I do this for a living. I can't tell which breast had the surgery, so this patient had a good outcome. So if our goal is for breast conservation surgery is to remove a lump of tissue that has the cancer, the question is, how do we know where the cancer is? Well, for a very long time, since the 1970s, we used this method called wire localized excision, or very simply, the radiologist would put a wire through the breast tissue, and the tip of the wire would be where the clip is, where they biopsied it, and where they biopsied the cancer, and that's where the cancer is. For 45 years, the technology has been exactly the same. We're limited by our technology. This is all we had, so this is what we used. Well, there's some difficulties with using this method, but like I said, all we had. One of the difficulties is, as a surgeon, you don't necessarily know exactly where the tip of the wire is. If you can imagine, when you're trying to remove a lump of tissue and you're saying, well, the tip of the wire is where my cancer is, I don't have X-ray vision like Superman. I don't have, you know, the electronic goggles like Iron Man. I have to use so-called the force. I have to look at the mammogram and use that as my guide. As you can imagine, it's very cumbersome, and sometimes it's difficult to do. What all that led to, using the wire, again, that's all we had for 45 years, was we were taking a large number of people back to the operating room. And we're taking these people back to the operating room because when we remove the lump of tissue, we don't exactly know where the tip of the wire is. We don't exactly know where the cancer is. So undoubtedly, some of these patients, we don't end up removing all the cancer. In large studies, we find anywhere between 22 to 57% of patients have to go back to the operating room for a second surgery. And this is for cancer. And that's a very difficult conversation to have to a patient, where I make an agreement, I say, I'm your surgeon, I'm going to take care of you, I'm going to remove your cancer. And then we come back and I see you in my office and I say, we didn't accomplish what we wanted to accomplish. So because of that, we looked for some better ways to do this. We looked for ways that were better than the wire. There are all sorts of ways that people have tried, but one of the ways that we at Florida Hospital have been very excited about is the radioactive seed localized excision. This method started at Mayo Clinic in Scottsdale, and they had the same problems we had. We were taking up to a half of our patients back to second surgery because we're not removing all the cancer. There has to be a better way. Well, this is the method that we use now, the radioactive seed instead of the wire, and this is why it's so much better. We inject instead of putting a wire through the breast tissue, we place a small radioactive seed about the size of a grain of rice next to the cancer. Okay, that's very important because this allows us to find where the cancer is. These are mammogram images after we have placed the seed. You can see the seed is exactly right next to where the biopsy clip is, and the biopsy clip is exactly in the center of our cancer. The reason this is so powerful and so useful is that I can use the seed to tell me exactly where the cancer is. If you guys ever been to the beach, you know, with a metal detector beach combing, same exact concept, a little more sophisticated equipment, but same exact concept. Well, I use a handheld Geiger counter, and I move it over the breast. The closer I am to the seed, the higher my counts, or the higher the pitch is. So if I'm over here, it'll go doot, doot, doot. If I'm over really close, it goes doot, 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 doot. I can use that as my guide to see exactly where the seed is, and remove the cancer in total. This is what breast cancer looks like when we take it out. It just looks like regular tissue. Just take my word for it. I do this for a living. This is regular. It's hard to tell the difference between breast cancer and regular tissue. We put some stitches on here to mark the orientation. And then after we remove the cancer, we send it to the radiologist to get an X-ray to confirm that we have removed the cancer. So this hazy area out here is the cancer. Right in the middle, this is the clip where the radiologist did the biopsy with the ultrasound. Right next to the clip is the seed. Around the cancer, there's a rim of healthy tissue. This is the ideal excision. We want to remove the cancer with a rim of healthy tissue to maximize our chances of removing the entire cancer. Let me compare that picture with the previous picture I put up. So again, we have the cancer, the seed, the biopsy clip, and a center of normal tissue. It's a little harder to see here, but the tip of the wire is right here at the very edge of our specimen because we had a hard time knowing where the wire is. The biopsy clip, it's hard to see, is right here. The tip and the wire aren't exactly in the same place, and by no means are they in the center. This patient had to go back for another surgery because we had left more cancer in than we should have, or that was ideal. So this patient had to have a re-excision. This patient had excision to negative margins, which is ideal. We were so excited about this that we decided to write up our experience. So we compared our experience using the wire, which is all we have initially, and we compared that to our experience using the radioactive seed. We had very, very good experience, very good results. We decreased the number, this is at Florida Hospital, these are our numbers. We decreased the number of patients we were taking back for a second surgery by 75%. 75%. We found that we were taking over half of our patients back for a second surgery using the wire. Again, we were limited by our technology, but there's something better, the radioactive seed. So we went from taking over half of our patients back for second surgery to 16% of our patients back for second surgery, and for various reasons, but less so for the fact that we didn't remove all the cancer. Kind of speaks for itself. So I want to talk a little bit about mastectomy, because breast conservation surgery is, although it's what we offer to most patients, some patients aren't candidates for breast conservation surgery. In these patients, we would offer them mastectomy. Mastectomy is removal of all of the breast tissue, and usually we also sample the lymph nodes as well. So instead of taking a lump of tissue out, we remove the entire breast tissue, including the nipple. It's a much more extensive surgery, but for patients for patients that can't undergo breast conservation surgery, this is the option. The reasons why we would offer mastectomy as opposed to breast conservation surgery are if the primary breast cancer cannot be excised with a reasonable cosmetic result. If the breast cancer is very, very large compared to the volume of breast that the woman has, it doesn't make sense to remove just that portion and then remove leave a little sliver of breast tissue, in which case we would recommend a total mastectomy. Also, and this is this is in the very general sense that when we do a mastectomy, we remove all of the breast tissue. That avoids radiation therapy. Because we're not leaving any breast tissue behind, we don't need to irradiate any breast tissue because we've removed it all, including the cancer. So for patients who can't tolerate radiation, mastectomy would be an option. Also, carriers of gene mutations, such as BRCA, that Dr. George talked about, those patients are at higher risk of having breast cancer. So even if they do have breast cancer in one breast, sometimes we do offer mastectomy, not only in that breast, but also the other breast, to lower their entire risk of having breast cancer. We find that mastectomy doesn't necessarily decrease your risk to zero. The reason is this: as hard as we try, we can't remove all the breast tissue. We remove the majority of it, but undoubtedly we leave some breast tissue behind, and that breast tissue has the potential to harbor to have cancer later down the line. And this is ultimately what it comes down to: patient choice. Some patients come into me, they're very enthusiastic about breast conservation surgery. They want to have the least amount of surgery as possible. They want to keep their own breast and have their own tissue. Patients who, and there are on the other spectrum, there are patients who say, just take it all off. Give me the full Angelina, is what they say. They want to remove all the breast tissue because they're worried that they have cancer now. They don't want to even deal with it at the end. All these concerns are perfectly valid, and it's very patient-centered. And we have a very frank conversation about what our goals are between the surgeon and the patient, and we come to a reasonable recommendation. When we talk about patients who we recommend mastectomy, we kind of talk about them in terms of the patients we rule out for breast conservation surgery. These are some well-known contraindications or reasons why patients would not be recommended to undergo breast conservation surgery. If there are 2 or more lesions in separate quadrants of the breast, we talked about the breast being divided into 4 different quadrants. Well, if the patient has 2 different types of cancers or 2 lesions, one in the upper inner quadrant and one in the very far outer lower quadrant, they're very far away. For this patient, I would recommend mastectomy because they're in 2 different quadrants. It just doesn't make sense to remove a lump of tissue here and a lump of tissue here. It would be quite deforming, and the oncologic result, or the result that we want to remove all the breast cancer, would be compromised. If a patient does undergo breast conservation therapy and they have what we call positive margins, or we find that we haven't removed all the breast cancer, usually what we do is we recommend a re-excision, or taking the patient back and removing a rim of tissue around where we perform that surgery. If that patient has had a re-excision already, or has had multiple re-excisions, we recommend undergoing mastectomy, because there's only so many times that you can reasonably go back to the operating room for a re-excision. Also, if a patient is pregnant, that's a contraindication to radiation. So as we talked about, breast conservation surgery isn't just removing a lump. It's removing a lump, sampling lymph nodes, and radiation. You have to have radiation if you want to go through this process. For pregnant patients, we find that the dose of radiation we have is very toxic to the fetus, and we don't have very good ways of shielding the baby from the radiation, so we don't recommend breast conservation surgery for pregnant patients for that fact. There are little subtleties where sometimes we can provide breast conservation surgery for pregnant patients, but generally speaking, pregnancy is a contraindication. Also, history of prior radiation. It may sound, kind of odd. Why would someone have radiation before? Well, if someone had radiation to the chest, had some sort of disease where they would need radiation to the chest. We think about lymphoma, or sometimes other kinds of malignancies where they've needed radiation to the chest before. The body doesn't do well with multiple doses of very high doses of radiation. You have really bad results. So unfortunately, those patients, we would probably recommend mastectomy to avoid the toxic dose of radiation. So those were absolute contraindications. When you go talk to your oncologist or your breast surgeon or radiation oncologist or your doctor, those are the known reasons why patients would not have breast conservation surgery. Those are hard no's. These are relative contraindications. These are reasons why we would kind of tap the brakes a little bit. Not necessarily saying you can't have breast conservation surgery, but we're going to think about it a little bit more. These are absolute contraindications. I'm sorry, relative contraindications. History of scleroderma or systemic lupus erythematosus, that's a mouthful. What that means is connective tissue disease. The reason why we would maybe not recommend breast conservation surgery for these patients is that patients with connective tissue disease, their skin doesn't heal very well, and if you apply a large dose of radiation to the skin, they have really bad results with healing and that kind of thing. So we recommend against radiation, generally speaking. Also, a large tumor, a very large tumor, in a very small breast size. It just doesn't make sense to, again, remove a big lump of tumor and leave a little sliver of breast. We would recommend mastectomy because the results would be just cosmetically unacceptable. So again, just to review, mastectomy is the removal of all breast tissue in the nipple areolar complex, and we also stage the lymph nodes just like we do with breast conservation surgery. We sample the lymph nodes with that are most likely to harbor the cancer, and if there is cancer in there, then we remove all of the lymph nodes in the axilla. These last few slides I want to bring up because I kind of have an axe to grind. So there's been a lot of talk in the press, Wall Street Journal, even in the Sentinel, New York Times, and about the changes in recommendations of mammograms. When should women get mammograms? The United States Preventive Services Task Force has changed their guidelines and recommended that instead of getting your first mammogram at 40, if none of your family members have breast cancer, to getting your first mammogram at age 50, and instead of getting them every year, you start getting it when you turn 50 every other year. Well, people who do this for a living and take care of breast cancer patients for a living know that there's a big difference in outcome when you see a patient who has early breast cancer versus patients who have very late or advanced breast cancer. Florida Hospital Cancer Institute and American Cancer Association does not agree with the United States Preventive Services Task Force guidelines in this case. We recommend getting your first mammogram at age 40 and then yearly thereafter, and if you have a family member with breast cancer, starting earlier than that. The reason is this: the earlier you catch breast cancer, the better your outcome. We have a lot of new techniques. That improve breast cancer outcome, but the patients who see the most benefit from these new techniques in terms of radiation, even the radioactive seed procedure, and some of our chemotherapy and endocrine drugs, those patients have early disease. The patients who present with big, giant tumors that have been going on for a very long time, that have a very severe disease, there's not a lot that we can provide for the patient in terms of improving their outcome for disease-free survival. So for that simple fact, I do not recommend. I do not agree with the recommendation of getting mammograms age 50. Start at age 40. Thank you guys again for coming tonight. I think the message here is that breast cancer is treatable and beatable. Breast cancer is not what it used to be. We're catching breast cancers earlier. We have better techniques at treating breast cancer, and early diagnosis is the key. This is if you go to the Florida Hospital's website here, join the Pink Army, you don't even need a prescription for a mammogram. You just sign up. You can get your yearly mammogram, follow up with your primary doctor. You can follow up with Dr. George, Dr. Constant Peters. You can even follow up with a breast surgeon, as long as you follow up and get your mammogram. Thank you very much.